Good. All right. So welcome to the next in our guest speaker series. And we always give a quick introduction to Oxford Brain Diagnostics, Craig. So we're an Oxford University spin-out with a method for analysing brain MRI based on cellular structures. We're working towards a clinical tool for early detection of Alzheimer's disease and other neurodegenerative diseases to be used by clinical services and also drug developers as well. So today we're very grateful that Professor Craig Ritchie has joined us. He studied medicine at Aberdeen University and his PhD was at UCL. And then after some years, I believe, in London, he returned to Scotland. And Craig, you're now there as Professor of Psychiatry of Ageing at the Centre for Clinical Brain Sciences in the University of Edinburgh, and co-coordinator of the large European EPAD project and various other chairs of all sorts of consortia and things, I think, in Scotland, and also, importantly, director of Brain Health Scotland. And so I know you've recently released a paper which is summarising the development of Brain Health Scotland and the new system there. So we're looking forward to hearing something more about that. And the title of your talk today is The Scientific Basis and Clinical Developments for Brain Health. So you have the virtual floor.
So can you still see my slides okay?
Yes.
Yeah. Okay. So thanks very much for inviting me. Thanks for the introduction. And I think, you know, what you outline your company's ambitions are, I think, dovetails very nicely with, dare say, what I'm going to present, because I think what we've been learning over the last sort of 2 or 3 decades about Alzheimer's disease is really ripe, if you like, to, I think, really transform clinical care and clinical practice. And one of the key parts of that, as this title slide alludes to, is early detection. So what I'd like to do just in this 30 minutes or so is highlight, I think, a change in the direction of travel that has been mediated, I think, by studies across the world, but obviously EPAD and PREVENT, which is a cohort I run of midlife individuals, is confirming what I think a lot of us suspected already, and that is that the diseases that lead to dementia in later life certainly have their genesis at least in midlife and maybe even earlier, and that obviously opens up the window for early detection at a stage of disease when interventions are likely to be a little bit more effective than they are when you test them or you treat people later in the course of the disease. And I think in the second half of the presentation, what I'll talk about is the way we're trying to develop clinical services and other services, public health and policy services in Scotland, to map onto these research developments to try and create this new kind of ecosystem whereby research gets into practice very rapidly, but also can help generate data, which kind of improves the research delivery and discovery moving forward. So look, I don't probably have to go into any sort of basic neuropathology with this group, and I'm not a neuropathologist, but I always think it's useful to remember in many ways where this all started in terms of Alzheimer's disease. And obviously Alzheimer's on the left, Auguste D on the right, way back at the turn of last century, 1907, was the first time that Alzheimer's was described in the brain of Auguste D, who was in her mid-50s at the time. And I think, I'm a psychiatrist, and I think it is very, very worthwhile remembering that Alzheimer's disease is a brain disease. It's a pathological condition. It's defined by pathology. When we see people in clinic and we say they've got Alzheimer's dementia or mild cognitive impairment due to AD, we always preface it by saying probably, probable, what have you, because until recently, we haven't really been able to detect these disease processes in life, and it's been a post-mortem confirmatory diagnosis. And these are cartoons that Alzheimer's scribbled down in his notebook through the light microscope, and of course these are principally the neurofibrillary tangles on the right and the amyloid plaques on the left. So these are the two core pathological lesions in Alzheimer's disease. We know, of course, that amyloidosis may happen in a benign sense as we age, and we know there are other diseases where tau has a relevant role. But we have to remember that Alzheimer's disease is a brain disease. The problem back in 1907 was that there was no way, as I said earlier, about identifying these disease processes in life. So we necessarily had to rely on approximating to what we thought might be happening in the brain through a phenomenological approach, symptoms, cognitive symptoms, behavioral symptoms, impact on function. So really since 1907 till the current day, dementia has been a syndromal diagnosis. Now, I do reflect often that in the 1990s, had we been maybe even more brave, we could have said, great, we've got CSF biomarkers, we've got neuroimaging, and then later on we had not just structural imaging, but also metabolic imaging of amyloid, and now more recently, of course, of tau itself. In some ways, that one could have argued that should have been the moment when the field said, let's not abandon completely, the symptom profiles as being important, but really we should be defining this disease as a brain disease rather than as a clinical syndrome, because we can actually measure it. Unfortunately, that didn't happen. I think there's a lot of legacy issues. We still continue to use these as memory disorders, memory clinics, memory drugs. But of course, that's like saying in oncology, the cancer is a pain clinic or a pain drug or a nausea drug or a nausea service. So I think we have to really try and transform this into what a friend of mine, Steve Salloway, once said, into modern Alzheimer's disease. So this little cartoon just illustrates what I've been saying, that the world until now, and I wrote this slide several years ago, not just in preparation for this talk, but this slide illustrates that until very recently, we have always been considering the Alzheimer's disease through the lens of the older person with a dementia syndrome. And necessarily that means that when we look at cohort studies in these populations, when we look at clinical trials and in delivering clinical trials, we have to do it and we understand this disease at that very late stage. And of course, we all know that drug trials for disease modification, at least, are not being successful in this clinical population. I mean, in some ways you could argue, to go back to the oncology analogy, this is the terminal phase of the disease. This is the palliative care stage of the disease when it's spread and metastasized, if you like, throughout the brain, in inverted commas. So what we've had to do, and we've certainly been doing and also the point being made there is that we rely incredibly heavily on the most observable symptom for the patients and the clinicians, which is memory. So what we've been trying to do, I guess, over the last year, certainly through cohort studies, is turn our gaze to the earlier phase of the disease when we expect that the disease starts. It'll be in its infancy, whether it's being, the processes that when we look at things like the Clifford-Jack slides, we hypothesize that there's a sequence of events, but who's to say that those sequence of events might be quite different if we were actually to have the data, the empirical data, to work out the relationships, for instance, between neuroinflammation and cerebral blood flow and, genetic and other risk factors. So that's what we've been doing in these cohort studies, is really trying to move ourselves back in time to see what's happening at the earliest phases. And the emphasis here now has to be on biomarkers, because almost by definition, these people won't have clinical symptoms. People with early breast cancer or early cervical cancer don't necessarily have symptoms, and it's only through screening, through mammography or cervical screening smears, that you actually pick up these diseases. And I think that's a good analogy for what we could and should be doing in the near future with neurodegenerative disease. And the other thing we have to think about in terms of, dare say, clinical services is, well, we're not going to be, at a place, and nor should we probably be at a place where we screen the entire population for the presence of amyloid or whatever it might be, which is relevant. We need to understand who are the high-risk populations, who are the targeted populations that maybe particularly benefit from early detection. And to that, we know obviously the age is the major risk factor, but there's also other risk factors, a complex interplay of risk factors that will increase or even decrease an individual's risk of developing Alzheimer's disease. And the other thing which I think is very important from this slide, which I show again in the next slide, is that some of these risk factors maybe have a potency around a certain stage in one's life. So for instance, high blood pressure, diabetes, obesity maybe more potent as a risk factor in midlife than they are necessarily in late life. In fact, there's even evidence that being slightly overweight in late life might be protective, but being slightly overweight in midlife is a risk factor for Alzheimer's disease. So this has been quite nicely articulated. I mean, I think a lot of us knew this already before the paper was published, but it was good to see this in a way that was accessible, if you like, to a broader community. The Lancet Commission report, which Jill Livingston published and republished, I think, just last year, highlighted that there are these modifiable risk factors that operate across the life course that may be responsible, certainly in sort of wealthier communities where these cohort studies were done, for about 40% of the risk of developing dementia. So one of the things I think that this really provoked was two challenges. The first challenge was a clinical one. How do you turn these epidemiological observations into actionable individual prevention plans and public health policy? But I think there's an equally important scientific line of inquiry about, well, how does hearing loss increase your risk of Alzheimer's disease? How does exercise or lack of exercise? So can we unpick a mechanistic understanding between the risk factor and the disease process? Of course, one thing, of course, worth mentioning is that these epidemiological studies used as their outcome dementia. They weren't looking at exercise and amyloidosis. They weren't looking at alcohol consumption and spread of tau. They were again looking at this clinical syndrome. So who knows whether or not maybe slightly different results had there been slightly different outcome measures from the studies. So how do we take this forward into sort of, if you like, into both an analytical platform or an analytical approach to the data that we generate in cohort studies, and how do we transfer that into clinical practice? So I think of this 4-factor modeling that we've been describing, where you have to have data on the risk factors, both fixed and modifiable. So that's your lifestyle factors, your medical comorbidities, your genetic risk factors, etc. You have to have data on how the disease expresses itself through biomarkers like neuroimaging, CSF, blood-based biomarkers, etc. You have to then work out how the disease expresses itself clinically through cognitive measures, behavioral measures, neuropsychiatric symptoms like sleep and apathy and these types of things. But critically important in any of these modeling approaches is having the ability to look at change in these factors, and that's where the 4th dimension, if you like, time, comes into these equations. So that's why from a cohort study perspective you need long-term follow-up, but from a clinical perspective you're probably going to learn a lot more by seeing a patient on 2 or 3 occasions to really help understand what is going on and what their prognosis is likely to be. So high quality data sets were obviously the necessary first step, and the PREVENT study, which I'll show a couple of papers from, outcomes from in a moment, 700 people, baseline age between the ages of 40 and 59, very deeply phenotyped, and now followed up to, in the London part of the cohort, up to for several years of follow-up. I think I mentioned the mean age in this cohort at baseline is 52. So you are talking about very much a sort of midlife cohort. EPAD, slightly larger cohort, which I was also privileged enough to lead on, running across the whole of Europe. On this occasion, 2,000 people in the study, mean age now 62, but still younger than typically you'd see in, for instance, ADNI or ABLE. So they're very complementary. So you've got, 4 really big studies: PREVENT, EPAD, ABLE, and ADNI, which really span the life course and doing very, very deep phenotyping. And that's why it's important. One of the other initiatives I'm delighted to be involved with, which is at the ADDI, the Alzheimer's Disease Data Interoperability platform. The EPAD data is on that, the PREVENT data will be on that, and these are the places where I think from a research perspective you can have access to this, the really high quality data sets in a way that's very easy, hopefully, to analyze and draw conclusions from. So just very quickly on PREVENT dementia, 700 people, like I say, completed baseline assessments just a few months ago. Up to 5 years of follow-up in the London centre. We've got another grant just gone in to try and get the follow-up in the other centres across the UK and Ireland. Alzheimer's Society took a big, it's probably worth saying actually, 2012 we put this grant together. There's a huge amount of cynicism just a decade ago from our peer reviewers about whether or not dementia was preventable. And I remember vividly some of the comments back from peer review, which were quite brutal in some ways. Why are we doing this in people this young and all these types of things? Myself and Craig Ritchie had to be interviewed for it, and we got asked, you know, why are you doing it in people so young? And Craig Ritchie, who's an epidemiologist in Montpellier in France, very quickly said, oh, I thought we weren't going young enough. That put that question to bed quite quickly. But I think that you have to call out the Alzheimer's Society for almost being brave enough to fund this, because it was at a time when there was a lot of cynicism, which seems almost crazy 10 years later, about the possibility that this could be a midlife disease and indeed preventable. So I won't dwell on this. I mean, it's just to highlight the depth of phenotyping and clinical assessment that our cohort, share their time and their data with us. And imaging, which is particular interest to this group, our imaging lead is John O'Brien at the University of Cambridge, and his group in Cambridge have been hugely productive in putting some really interesting data together of some quite novel findings, particularly around things like connectivity and blood flow. And we've also got blood on everybody's CSF, etc. So, you know, a good data set to explore some of these interactions between risk factors and early expression of disease. And one of the other things which has come from this project is a lot of, you know, sub-studies, a lot of add-on studies, which have been really exciting. So around the core project, we've got, again, John leads on the amyloid imaging and prevent study, which we have 300 capacity to 300 amyloid scans. There's a 7T study just finished in Cambridge where 50 people have been scanned, and 100 people have had virtual reality assessments looking at visuospatial memory, which I'll come on to in a minute. In Edinburgh, we've got a sub-study looking at retinal imaging, which has seen well over 100 participants. We've just started, actually, a PET tau study with Paresh Malhotra and Imperial doing PET tau, and the list goes on. I think it's worth highlighting one of the other areas we're particularly interested in is around head injury. So we've got some quite substantial funding to look at ex-professional rugby and football players. And also, in terms of head injury, unfortunately, there's a very high prevalence in the cohort of head injury due to intimate partner violence. So we're being able to look at that in that particular group of women to see whether or not there's any issues there that we can help with moving forward. So just a couple of papers, just to sort of illustrate some of these points before I talk about Brain Health Scotland. So if we make the assumption, and I think it's fair to say that at the moment we believe that Alzheimer's disease starts in the hippocampus, so we've got some data that might be the locus coeruleus as more of a role. But anyway, in terms of the hippocampus, yeah, let's drill down in the hippocampus within the prevent cohort. How do you test it? Well, from a structural perspective, we know that hippocampus can be subdivided into these subfields, which we can image, through appropriate pipelines. But we also know that hippocampus does things. It helps us do things, particularly on a visuospatial perspective. And this is obviously the work around hippocampal place and grid cells. So how can we see it? What does it do? So how can we measure it? So one of the tests we do within Prevent and indeed EPAD is something called the Four Mountains test. Now this test is to look at this scene of four mountains. I don't know how well it sort of transmits, but there's four mountains on this scene here. And what one has to do is look at the orientation between these four, 1, 2, 3, 4. And what will happen is, as happened, the slide advanced automatically, is the participant would be asked to look at, or the patient would be asked to look at 4 options, only one of which is the same scene from a different perspective. So look at the 4 mountains, and then here's 4 scenes, one of which is the same 4 mountains, but from a different perspective. And this is a very good test of what we call egocentric visuospatial memory. Okay. Now, this isn't like doing the MMSE. This isn't like doing the CDR sum of boxes or the R bands. This is tough. And this is probably drilling down very nicely onto the hippocampal subfields, particularly CA1 and molecular sublayer, which we'll come on to in a minute. The answer is A, by the way. And what we did in the Prevent studies, again, I mentioned Craig Ritchie earlier, she looked at the relationship between performance on the Four Mountains test and other cognitive measures, and a risk score for dementia called the CADE score, which has come out of Mia Kivipelto's group, which is weight, age, sex, education, APOE, etc. And lo and behold, this risk factor score for dementia seemed to predict poor performance. Higher scores in the CADE predicted poorer performance in the Four Mountains test. And remember, this is a group of individuals whose mean age was 52 years old. So here we're seeing quite strong evidence that a risk for dementia in later life was already expressing itself as a cognitive impairment, not around memory, but around visuospatial function. And to complement that, Mariolina Denavi in John's group in Cambridge looked at the same sort of domain, if you like, but through an imaging perspective, looked at the hippocampal subfields and the relationship with the genetic risk, of course, for Alzheimer's disease, which is ApoE4. And lo and behold, found that both at the baseline sample and in the 2-year follow-up sample, there's a significant association between ApoE4 status and atrophy of the molecular layer of the hippocampus. And this is a region that we know to be affected early when we look at sort of Bragg staining by NFT, by tau buildup. So, you know, we're triangulating. We're seeing visuospatial function being affected clinically or by measuring it through the Four Mountains test. And in the same cohort, we're seeing atrophy, or not atrophy, we're seeing smaller molecular sublayers relative to ApoE4 status. So, to my mind, well, you know, we obviously need to look at this in more detail with larger samples, follow up people for longer, etc. But it does, I think, not confirm, but it certainly supports this hypothesis that there are changes in the brain, which modern cognitive techniques and more modern MRI techniques may be able to pick up at a very early stage of disease. So, I think 3 or 4 years ago, I was looking at these data coming through. I was talking to the research participants, both in EPAD and PREVENT, and I kind of felt that there was a to confirm these things, to absolutely sort of nail it, was going to take us 10, 15, 20 years of follow-up. We had to wait for people to develop dementia syndrome. And I felt that that's too long to wait. We probably need to act now in terms of putting some of these observations into practice, as long as we were doing no harm and patients weren't being exposed to any safety concerns. So I took this sort of argument to the First Minister here in Scotland. She listened and she agreed that from both a public health and a policy level, maybe based more on the Lancet Commission report, and from a clinical practice level, maybe based more on the PREVENT cohort and EPAD, we should start getting research into practice, and that mediated the launch of Brain Health Scotland. And all of our branding, all of our marketing, so this is Scottish Government funded, it's hosted by Alzheimer's Scotland, which is a charity up here, like Alzheimer's Association Society down south. All of our branding, all our marketing is around midlife, and it's around brain health. It's not about dementia prevention, it's not about disease, it's more optimistic, it's about maintaining brain health, and open brackets, to prevent dementia, close brackets. And this was the ambition. We obviously started this a couple of years back before COVID, but the idea was that through our activities and coordinating activities and in starting new activities here, we would be able to optimistically reduce the incidence rates of dementia year on year. We know that the incidence rates of dementia are probably dropping anyway in most Western countries, but the incidence of old age is increasing, so the numbers of people with dementia is still on the rise. So we thought, if that's happening, if you like, naturally, how much could we do if we how much could we achieve, if we were more purposeful in trying to really lead campaigns at a public health policy level and also set up new clinical services. So if we think about the clinical services, again, the thinking behind this isn't unique to what we're doing in Scotland. My friend and colleague Giovanni Frassoni, who's in Geneva now, we spent a lot of time talking about this, dare say, with the EPAD consortium, people like Philip Shelton, so with Molnievo. We all get together. It's a community of practice. We were having the same thoughts. And this was articulated in this paper, which Giovanni and I led on. It's this notion of, risk profiling, early disease detection equals a personalized prevention plan. And this crazy illustration is of a man in his 60s who comes into a brain health clinic and has a full assessment. And because of these risk prediction algorithms we'll be able to build over time, we'll incorporate all of these different data. We'll be able to say to that individual, your risk of developing dementia, if that's the outcome we're interested in, is 73%. But not only is it 73%? But these are the contributing factors to that risk. Lifestyle at the top, genetic, diabetes, and a little bit maybe of emergence of amyloidosis, so a biological component to that risk prediction model as well. So what do we do? Say, well, look, the best way to address this risk at the moment is to manage your lifestyle, to manage your diabetes. And lo and behold, comes back a future date. His age has increased, but his weight's been controlled. His diabetes is now better controlled as well. So actually his risk has gone down when you rerun the algorithm. However, despite modification of risk factors or management of the risk factors, the biology, the amyloidosis, maybe some early tau spread from areas around the hippocampus. So we're now seeing a little bit of the biology emerging. Now what we do with this young man is say, okay, we're going to put you on a disease-modifying therapy. And this child might be completely asymptomatic, but we've recognised that this would be somebody to target with a monoclonal antibody, be it anti-tau or anti-amyloid, or maybe a combination of the two. Comes back after treatment, and you now see that his risk has dropped even further, and he's now 80 years old. This guy is not going to die with Alzheimer's dementia. And this is I know this is a crazy illustration, but this is the kind of the approach that we want to be taking in clinics in the very, very near future. So this was, I think an important paper for us because we brought together, I think it was good to bring together into the one place all of this thinking. And as people know, when you write a paper, it forces you to really sort of crystallize your thinking. So the co-authors in this sort of variety of people across the landscape here in Scotland. So you've got people who are neuroimagers, Jerry Thompson, you've got statisticians, Graciela, you've got Sharon Simpson at University of Glasgow's about, she works in health equalities unit. So a variety of people on this paper. Dominic Trappel, by the way, is a health economist, which I think is critically important as well. And what we laid out in this was this kind of Scottish model for brain health services. Just maybe 3 or 4 more slides to go. But the top panel is illustrating how these clinics don't sit in isolation of other initiatives up here. So we've got responsibilities for public health, for developing policy. We've got work, as I said earlier, looking at people with more targeted populations, be that women who've been subject to intimate partner violence, ex-rugby, football players, people who've played contact sports. But probably the biggest target population is those with a family history of dementia, because they're a very motivated group, and they're also, as we know, at slightly higher risk. In the clinics themselves, which will be launching over the next literally few weeks, then there's this kind of triaged approach to taking people in the front door. There'll be community-based, open access clinics. People will come in the front door, they'll have an assessment. If that assessment suggests that they may be at slightly higher risk, then they'll see a nurse, who'll do further assessments. If they're deemed to be on the basis of those assessments, and those assessments will be eventually run through a decision support tool using all the data that we're generating to help develop those algorithms. Then they may see the doctor, have a brain scan, have spinal fluid, have other imaging done, and then you'll put together the personalised prevention plan, which at this stage, of course, would be about risk factor modification and maybe entering into a clinical trial, but hopefully in the not too distant future, this will be a fantastic setting, if you like, for not only doing the drug trials, but also getting people early into the phase 4 trials, which we know are all going to be necessary for the disease-modifying therapies. Risk profiling, as I mentioned, so very comprehensive, sleep, diet, exercise, medical comorbidities, all in there. We've also, and I've highlighted ApoE, we also want to do ApoE very early, because I think if we're blind to their genetic status, it seems like we're kind of like, missing out a big component in that risk prediction model. So we've talked to our, neurogeneticist colleagues, Mary Porteous, who's on the paper. She's very comfortable that in the right hands and the right circumstances, which these are, then you should be doing ApoE and you should be communicating that back to the person, and that might help motivate them, dare I say it, but also helps to really understand what their prognosis is as those models develop. In the early disease detection and expression in routine clinical care, we've got a standard imaging protocol which Jerry Thompson's been pulling together. we were talking about putting a massive infrastructure together to get CSF, but I think the availability and the development of blood-based biomarkers is going to be transformative, so we'll be using those instead. And also we're going to be doing, expression of disease through cognitive testing. We've got a standard test battery for that, which is quite reliant on something called the digital clock test, which you may know of from Linus in the US. Of course, what it also creates is this wonderful, I think, laboratory almost, where you can test new technologies. So all these, it's almost like turning this into a big cohort study where you've got all these fantastic core data in the NHS, but you can then, add on more novel technologies and compare it against, gold standards, reference standards, if you like, that we've been collecting already. So hopefully it will improve the life sciences capacity of Scotland to help deliver these things. So just to sort of build on that a little bit further, data and secondary research, we will have a single data system for all the brain health clinics. That'll help us to, well, it won't help us, it'll be critical to develop these risk prediction algorithms with all these data that are being collected in an unbiased fashion. And that will then feed, of course, into communicating those the outcomes from those algorithms in a way that's accessible not just to the clinician but also maybe to the patient. So the decision support tools will obviously have to be very user friendly for the clinicians working there. And they provide, I think, a natural secondary research setting, like I said, for further development and evaluation of early detection techniques or interventions or other research that may be appropriate. And all the data will be in the NHS, but with consent on something we call the Scottish Brain Health Register, those data can be made available to researchers elsewhere. One of the things I often get asked is who's in and who's out. I mean, this clinic, brain health, that's a broad concept. Brain tumor, that's brain health. Are you going to look after brain tumors? Well, of course we're not. So I think what we've had to do, and we articulated in the paper, is that we're really interested in people where their brain health concerns are most likely to be due to neurodegenerative disease. But I think we've also got within scope the ability to treat and manage those risk factors, which are maybe more specific and unique to neurodegenerative disease. So things like depression, anxiety, etc. So let me just skip through that slide just for the sake of time. But one of the other things we also get asked is, is this relevant? Will people engage from the general public? So late 2020, we did a survey with Ipsos Murray of the Scottish population, and the papers of the publications available on the Brain Health Scotland website. But some really key things emerged, and number one was that when we asked people about that, almost like the Lancet Commission report 12 things, it was clear that people hadn't really realised that these things were important for brain health. Keeping mentally active was seen to be kind of the most awareness around as potentially being helpful for brain health. But things like avoiding injury or looking after one's mental health, aka depression, anxiety, wasn't seen as relevant for Alzheimer's disease. But the interesting thing was that wasn't because people weren't interested in brain health. I haven't got a slide here, but actually people were as worried, this is a midlife group, were as worried about brain health as were about risk of cancer and heart disease. So the disconnect between a concern about brain health and knowledge or health literacy about what one can do to improve brain health. So for us, this was actually very encouraging data. There was a knowledge gap that needed to be filled, but there was certainly an appetite within the public to do this. So this is what led us to, in the first instance, think about, well, how can you actually purposefully help people achieve risk factor modification? So we've done a lot of work with colleagues at Heriot-Watt University and the University of Stirling, behavioural psychologists, health psychologists. And what it's drilled down into is an easy way to, if you like, improve health literacy by breaking down the 12 Lancet Commission reports into bite-sized pieces which the public can wrap their arms around. So rest, medical fitness, socialising and learning, harms, food and exercise. And with that information, then they can do what's called create a personalised prevention plan, pledge, sorry. So step one is improving health literacy. We've got campaigns going on to try and do that across the country. Then people make what's called a personal pledge, and that personal pledge will hopefully modify the behaviour to an extent that people recognise if you like, get the positive feedback. So it's very simple, but the science behind this is incredible. I will improve my diet. How? By swapping meat for fish. When? 3 times a week. Where? At home. Who with? My husband, in this case, as an illustration. And actually, from this, a lot of this work actually stems from work in diabetes, where it has to be personalised. Going to see a doctor and a doctor saying, you need to eat better, does nothing. You have to own it. And this is a way that we will be able to do that in this particular community. So where do we do these things? Online. We've got an app we're about to launch and a website around that just in the next few weeks. We're working with Community Pharmacy Scotland to have any pharmacy you walk into Scotland will have this kind of, brochure or the app or whatever it might be. And we're training pharmacists to have confident conversations about brain health. Libraries, shopping centres. That's me just outside in a shopping centre just outside Glasgow, talking to people about brain health. Like I said, we've got very good relationships with the SRU and the SFA. So can we do more actually directly into those communities and the fans in particular? We've got a workplace programme going on with major employers in Scotland. And one of the most exciting things for me is we've also got a programme specifically for school children that we're going to be launching in April. Now, of course, we're not going to show them that literature. There's going to be different literature tailored to kids sort of 9, 10 years old, so they get off on the right step, if you like, with their brain health from a very young age. So, the final slide. Number one, I think the research direction is really taking us to, not even convincing or compelling, but it's a fact. The disease that leads to dementia start in midlife. So Prevent Dementia programme provided some of the evidence for that. And like I said, a big thank you to the Alzheimer's Society for stepping up and funding it 10 years ago. But it's also the conversations that I was having with the participants in that, or my co-investigators that were having, that was as important as the data that was emerging. They were saying, what's my risk and what can I do about it? And I thought we needed to improve the way we run clinical services to be able to support those individuals who are at high risk, potentially through family history or other risk factors. So that emerged into or led to the creation of Brain Health Scotland, which I've shown as a framework for this clinical pathway, but is also a wonderful setting for new research, be that clinical trials, and also, as we know, now it's going to be the case that if you've got a disease-modifying therapy launched, you're going to have to go through a major phase 4 stage. I think Scotland we're trying to set it up to be a place where those phase 4 trials can happen reasonably seamlessly. So I'll stop there and show you a wee photo of Glencoe. And yeah, it'd be great to have a bit of a chat over the next 20 minutes about anything that of interest.
That's great. That's wonderful. Thank you, Craig, for really quite an inspiring talk, I think. I didn't mention in my introduction that I actually owe a debt of gratitude to Alzheimer's Scotland. It was they who funded my fellowship, which was the start of my sort of focus on Alzheimer's disease neuropathology many years ago, and ultimately it's led in a way to this to forming Oxford Brain Diagnostics. And you may know that we often use the phrase that we are rethinking brain health, and I'm delighted that they continue to support innovation. And clearly, what you're doing is I think a major step forward in terms of managing and thinking about brain health, and also the knowledge gap you refer to. Is one that we would all, I think, like to tackle, and in our own small way, we hope that our measurements might start to be used in ways that can help people become aware of cognitive reserve and brain reserve, and how we can sort of fortify our brains against later diseases. So anyway, with that, and about 20 minutes, as you said, let's have some questions. Who would like to ask a question, Craig? Terry.
Yeah. So I was just wondering about actually motivating people to make these lifestyle changes. So if you look at the Lancet report, things like, hearing loss, give someone hearing aids would be straightforward. But everyone knows that, you have to be healthy and, don't eat too much, do exercise. But I think it's similar to a diagnosis of, risk of heart disease. You should be helped. But if you actually get diagnosed with the early signs, I think people make more changes.
Yeah.
And I wonder what we can learn from that when it comes to Alzheimer's disease, which is so difficult to sort of identify those early changes, where you see the balance between risk and we've identified something, there's something happening.
Yeah, I think that's exactly right. I think what it boils down to is sort of salience and personal relevance, and that has to be mapped onto are the things that you do or could do, are the actions you take going to make a difference? Okay, because there's no point in saying to somebody, well, you've got this high risk of developing Alzheimer's dementia. We've already noticed amyloid in your brain, but there's, in effect, even through risk factor modifications, very little you can do about it. Okay, so we don't believe that's the case because as you say, if you look at the Lancet Commission report as a starting point, if you were at a to improve diet or reduce rates of depression or social isolation, if people were to take those actions, then the likelihood is they are reducing their risk in the future. But I think the most important point to me, and I sound a bit cheesy, but when the First Minister said to me, so what's good for your heart is good for your head, I said, no, First Minister, what's good for your head is good for your heart. Because I think for a lot of people, the brain is a more important organ than their liver or their kidneys or their pancreas, if we're talking about diabetes. So there's a salience there that we picked up in this Ipsos-Murray poll, that people do recognize the importance of brain health. And the second point is that, I'm not going to do a poll of this group, but the frequency of having a parent with Alzheimer's dementia is much higher than, say, breast cancer or heart disease, even in Scotland. So there's a personal lived experience of not wanting to be like your parent and to take some action. And in fact, many of the participants in the PREVENT study were in there not because necessarily they wanted to improve their brain health or reduce their risk of dementia. They wanted to develop the science that meant that their children would not have to go through what they went through with their own parents. So I think the resonance of this approach and the salience of this approach to many people is probably a lot higher than it is for other conditions, because they've got that personal lived experience of having a parent or a grandparent or an aunt or an uncle with dementia.
Okay, thanks.
And if you can, and dare I say, if you can show that their hippocampus is atrophying or their amyloid is already beginning to accumulate, it's a little bit like cholesterol levels. People see a lot higher cholesterol, they'll take a statin. I'm often struck, sorry, I'm over answering, but I'm often struck by how good people are taking blood pressure medication and cholesterol medication. It doesn't make any difference to you the next day, and yet you pop it in your mouth every morning. It just seems incredible that we've managed to improve health literacy to an extent that people will take statins, will change their diet, will take high blood, antihypertensives for something that might happen in 30 years' time. We've done that. So can we do the same with brain health? I'd like to think that in the not too distant future we'll be routinely doing amyloid testing in blood from GPs, and we'll be on anti-amyloid therapies. Maybe not monoclonals, but certainly some of the oral ones in our 50s. It'd be brilliant, as long as it's cheap.
Yeah, okay, so other questions? Ian.
Hi Craig, that was a wonderful talk, thank you so much. I have a grandmother who's in bed in a vegetative state, and the first symptom that was obvious and for a very long time before she got cognitive issues was her hearing. I was really interested in hearing you saying that that hearing loss was a risk sort of factor, as in something that you should address, as opposed to a symptom. And I'm interested in hearing how confident you are that the causality is in that direction.
Yeah, I'll be honest, I'm not that confident at all. I think the reason the hearing loss emerged, and it was controversial because it was quite a big number in terms of the population attributable fraction, it would be the strongest risk for dementia. And from a biological perspective, it doesn't really, there's some hypotheses how it might be a sort of an epiphenomena, that hearing loss is obviously, driven by, neuronal integrity as well as so there might be an effect there, and there's pathways. I think, and I think a lot of people think, that because dementia is diagnosed on cognitive tests, your performance in cognitive tests is less good if you don't hear well. So if I'm in clinic, for instance, as I was on Tuesday, and I've got a patient who's got, if you've got a patient who's got subtle hearing loss, then they'll perform less well on cognitive testing, and therefore you're more likely to have a diagnosis. The second point about hearing loss is that people who have hearing loss are more likely to become socially isolated. And it might be, again, that hearing loss drives social isolation, and that social isolation and lack of stimulation may have a more biological route to neurodegenerative disease. So I think it's in a sense it's probably not on the causal pathway for amyloidosis or spread of tau, but I think it maybe accelerates the pathway to the clinical syndrome.
Okay, that's great. Thanks.
Yeah. But certainly from a management perspective, if somebody does have hearing loss, we manage it. I mean, anything that reduces your sensory abilities, be it hearing loss or taste or eyesight, if these things can be improved, you're going to engage more with people, and that's going to be a good thing.
Yeah, Mario, I think you were going to go next.
Yeah. Hi, Craig. Thank you for your interesting presentation. The clinical approach of brain health Scotland is based on these main principles: individualist profiling, early disease detection, and the implementation of personalized prevention plans. So, concerning individual risk profiling, the cognitive reserve can play a protective role, but is built during all the lifespan. So, do you think that a brain health approach should include even public health approaches to promoting brain health across the life course and improve cognitive reserve?
Definitely. I mean, I think there's two things about cognitive reserve, and I think the short answer is yes. I mean, we haven't literally we did another survey with Ipsos Mori to look at the prevalence of risk factors in the Scottish community. And this was really quite telling how socially isolated and how few hobbies and outside interests people have. So that kind of whole, as a proxy, if you like, for lifelong learning and intellectual stimulation, I think only about 37% of people were actively doing anything to try and do cognitively stimulating activities, be that being in a club or going to having a hobby or an interest. But so I think that's something which I think could be helped with, just to the earlier point. If you improve health literacy and make people realize that these activities really can be helpful in preventing neurodegenerative disease, or at least ameliorating its course, and therefore preventing dementia, building up cognitive reserve, cognitive resilience, if you like. The one thing, though, that and it's something I've just been reflecting on. Cognitive reserve is actually, could that be a problem, if you like? Because, dare I say it, I think of my dad. He's 82 years old, 81 years old. He's a former professor. He's probably got absolutely loads of cognitive reserve. So to the outside world, he's performing cognitively really well. However, he might be masking a lot of brain disease. Yeah. So is cognitive reserve something you actually want to try and achieve? What you actually want to try and achieve is somebody to be able to present as early as possible with their symptoms to seek help. Because if somebody's got a lot of cognitive reserve, and you probably know from the epidemiological data, that people with very high levels of intellectual capacity, lots of education, present later with a diagnosis of dementia, but their pathway is much more accelerated, because I'm not sure that having cognitive reserve does anything about the amyloid and the tau accumulating. You're just masking the amount of. So, I think we want to improve cognitive function. We want to, provide cognitive stimulating environments and lifelong learning. That has to be a good thing for the brain health. But whether or not, and I think this is where the Four Mountains test might come into its own, some of the tests that we can actually use, which maybe aren't as prone to cognitive reserve, might be the ones we want to actually roll out. Because we don't want people to do well on tests if they've got a disease. It's like somebody who's got a high tolerance for pain presenting really late with a cancer because they've just dealt with it because, you know, oh, I'm tough. You want them to come in early because by the time they present, it's metastasized. Just a...
Yeah.
I think that's
very often, but anyway.
I think that's a fascinating point. I mean, I think that this is where I would make the distinction between cognitive reserve and brain reserve, because
yes,
I agree that there is an issue with the masking, especially because the disease course is worse subsequently. But it would be hard. I feel it would be hard to argue that you'd remove people's ability to function better, to compensate, if you like, cognitively at least. But I think, you know, I mean, that's where, as you said, amyloid and tau assessments, but also the kind of thing that we're looking at, where we're looking at cortical disarray measurement in the brain, where we're looking at the kind of underlying neurodegeneration or the vulnerability to that in the architecture of the brain. I think that's, if we get a handle on those things, then we have metrics to discuss that, even if someone is potentially cognitively doing, you know, ostensibly quite well.
Yeah, and I think, you know, to the end of the day, you know, we don't treat amyloid, we don't treat tau, we treat people. And if you remain cognitively healthy and your brain's full of amyloid, then until you die of something else, so be it. That's fantastic. You know, you're well. You're well in yourself. But I think that's unlikely that we're going to be able to. There will come a point where the brain disease will become so extensive that no amount of cognitive reserve or lifelong education is going to protect you. So I think we have to try and do both. But I think the critically important thing, like it is for most other branches of medicine, is let's try and detect the disease, and then we could work out, you know, how we also at the same time help people to live with their disease as effectively as possible. But let's try and treat the disease, not just the symptoms. And I think one of the other things I didn't talk about, but one of the other interests that we have is around patient-related outcome measures, because I think in our space there's not been an awful lot of work of actually identifying with the individual what matters to them most in terms of activities that you would want to keep going with good brain health. And we published some papers on this a little while back on a program called EPS, Electronic Person-Specific Outcome Measures. We did this for the AR UK. 60,000 people we served, 6,000 people, sorry, we surveyed in the UK. And interestingly, a lot of the outcomes that people really want to maintain with brain health weren't cognitive. They were very much about being able to still interact with my family, being able to drive, play sport, So I think coming back to this sort of cognitive reserve thing and making people's, you know, helping people's cognition to stay as good as possible over the longer term, there's probably other things that are actually more important to people as they develop neurodegenerative disease, which we should maybe focusing occupational therapy on, social interventions to try and maintain. So that's just another sort of sidebar issue that we're also interested in.
Yeah, thanks. So I think we'll try and squeeze in both Jed and Omar. Jed, do you want to go next?
Sure, yeah. I'd like to ask a bit more about screening. You mentioned screening and gave examples of mammography for breast cancer and smears for cervical cancer. And I think you said at that point that we probably wouldn't screen for amyloid, but I'd be interested to hear more about your thoughts about, you know, under what circumstances we would try to screen, either using things like the blood biomarkers or using digital biomarkers, things like that. And is there a kind of funnel where you'd have certain biomarkers, you know, more widely available, more cheaply available ones leading on to perhaps higher performing ones?
Definitely, and I think I know this sounds blindingly obvious, but I'm going to say it anyway. You know, you do cervical screening in women. You don't do it in everybody. You do it in a high-risk population because they're more likely to have the disease. So you might have a screening program in bowel cancer over 50s. You know, what we'd probably want to do is say, well, is it a population of individuals that's so high risk at this first stage that we would screen that population? It's not population level screening, but you know, and that might be your ex-rugby player, your ex-football player, your person with a family history. The screening test, as you know, needs to be accessible, needs to be cheap, it needs to be effective, etc., etc. And I think the blood-based biomarkers are probably going to be at that stage at some point in the future, but maybe not quite there yet. So what we're doing at the moment is more towards, if you like, case ascertainment than screening. You know, people have to present to us and say, look, I'm worried because I've read this, I know about the risk factors, and I want to have an assessment. I think there will come a point, I really hope there will be a point in the near future where we will be offering screening on these blood-based biomarkers. And like you say, screen positive, sensitivity, specificity, high sensitivity tests, working towards specific tests as you go through the pathway. But yeah, we will get there, but we're not quite there today. I think maybe 5 years, that's what I'd like to. Yeah. I think it's feasible. I think that's where we should be heading towards.
Thank you.
Omar, I think you have a question.
Yeah, very quickly. It's frightening, actually. Morning, Craig. Thank you so much for your presentation. You'll be glad to hear that my hippocampus is working fine, because I did select A, and I was sitting nervously thinking, I hope you ring out A. So that's really good news. My question was around screening, but I think Jed's articulated it really well. So my second question was around the cohort of age groups that you showed earlier on in one of your charts, where you picked diabetes as a metabolic condition contributing to the various different ages. I was wondering why you picked diabetes. That's the first bit. And then secondly, later as we get older, how, and let's say I take myself and I'm bought into the whole brain health promotion, and I'm regularly checking my brain health, and I'm going to my physician. How do I check at the age of 80 that my lifestyle has made an impact, that my biology has made an impact, that my diabetes type 2 has made an impact in preventing the condition or disease or a dementia?
Why diabetes is, I think, from an epidemiological perspective, it's always shown up as a risk factor for dementia in virtually every epidemiological study. And I think there's a biological basis for that, maybe driven through neuroinflammation. There's also talk about the fact that insulin degrading enzyme in the brain is the same enzyme which we call neprilysin, which cleaves amyloid beta. So there's a series of biologically plausible associations between type 2 diabetes and Alzheimer's pathology. I think you've actually probably hit on one of the biggest challenges we face, which is how do you link the behavioral change to the outcome? Because the easiest thing I think about is if you've got asthma and you take your salbutamol, 5 minutes later you feel better, you know the salbutamol made a difference, okay? If the outcome you're interested in is weight gain, you can step on the scales. How do you know your brain health is better? And we've really struggled over that. We've really struggled, because do you feel smarter? Do you feel brighter? Do you feel more turned on? It's all going to be really loose. It's not going to be something which you can actually say measurably you've made a difference to your brain health. And even cognitive testing, to be fair, is unlikely over a short time course. If you change your diet, is 6 months later your 4 mountains test going to be better?
Yeah,
probably not. So we have to rely, I think, on like I was saying earlier, why is it everyone takes antihypertensives? Why is it everyone takes statins when the doctor tells them to? It's because they believe that something good or something bad is not going to happen in the future. So that kind of conversation, that argument needs to be quite compelling. That, we need to, as practitioners, believe and have the credible evidence that this is something that if you do now, you will have an improvement in your brain health or your risk of dementia in the future. But it's a dilemma. I won't pretend that. That we need to work out how you close that positive feedback loop.
Thank you. That's it. Yeah. I have lots of other questions, by the way, but
any smart idea, throw me an email, because it'd be
yeah.
Omar, you probably have a smart idea, don't you, Omar? If your hippocampus is functioning so well.
Yeah, well, I mean, one of the things, I mean, I'm gonna be unashamedly plug it, Stephen, but I kind of thought, I do feel quite strongly and passionate that neuropathology as a measure of improving or measuring brain health from one data point to the next data point, it definitely plays a massive role. And that's where, obviously, Stephen, the work that Oxford Brain Diagnostics is involved in our methodology has that. It's not the only answer. It's a combination of probably a different test. But I think we owe it to the patients as they get to 80 to say, well done. You've done amazing. Your CDM score over the years is this, and your biology is showing. There's a measure for biology, and it could be, your blood-based biomarkers are showing this. I think, Craig, it might be a host of reports that we share with the patient as they progress, and that's where we get the win.
Exactly. I know we're over time, but I think one of the things is that, for instance, I think you're right. I think if you have a biological measure like your blood pressure, you go on an antihypertensive, and you come back later and your doctor does your blood pressure or the nurse does the blood pressure and it's down. That's a surrogate marker for the risk of stroke and the risk of heart disease being reduced. Now, if you come back after 5 years and your PET amyloid or your blood-based amyloid is lower, or you've got better connectivity on some MRI measure, these are the things, not over the short time course, but over the long time course, saying that we think that intervention's made a difference. Now, there is evidence, and we did a literature review on the Mediterranean diet and hippocampal volumes. There is an association with better hippocampal volumes and compliance with the Mediterranean diet. The timescale for these things is going to be very, very long, though, and that's why I think you have to keep these people engaged in your service. It's not a one-off diagnostic factory. It's a service that you work on. You're on the journey with the patient for dare I say, many years. So a lot to learn, but I think the biology is going to be probably the best way to close that, like I say, positive feedback loop.
Yeah, yeah, we're a bit tight for time now. I'm gonna just make a little provocative statement or question, Craig, that you might want to comment on just before we finish, which is that a lot of the markers that everybody has been looking at are kind of focused really on the 2/3 of dementia that is Alzheimer's disease. And I wonder, is there a concern that in your pathway and in every other one that's using these different markers, you end up with a sort of overrepresentation of the non-AD below threshold dementias who might sort of escape the net, as it were.
Yeah, and I think we jump between Alzheimer's disease and neurodegenerative disease quite maybe sometimes too casually. I mean, AD is the example of a neurodegenerative disease, but these models should equally well apply to frontotemporal dementias and Lewy body dementias. And although we didn't say, there are CSF tests for alpha-synuclein, there's going to be blood tests for alpha-synuclein in the future. So I think these would have to be part of that. At the end of the day, we want to get to the etiology, and that etiology isn't just always Alzheimer's. And I think the other thing that this was actually, just to finish, this is one of the key reasons I did not want to call this, as they do in Europe, there was a big argument, they're not Alzheimer's dementia prevention centres, they're not Alzheimer's disease treatment centres, they're brain health clinics. Because in that, you can accommodate all of the different genetic diseases, not just Alzheimer's.
Yeah. Great. Well, that's a good point to finish on. Thank you very much for your time today, Craig.
Great. Yeah.
I look forward to our further contact in future AICs, perhaps. But thanks for your time just now.
Great. Thank you very much for inviting me.